break a lance here for orthotopic bladder substitution in females, why we should do it. Now, at the moment, the question seems to be more orthotopic bladder substitutes, why should we do it? Because there's a declining use of orthotopic diversions worldwide, and already in 2017, Hauptmann said, what went wrong? Well, he, at that time, said it was because a lot of urologists in Germany did a relatively small number of cystectomies and thus avoided the more complicated surgery with a urinary diversion and the postoperative management, which is more intense. The other issue was the emergence of the robots, or robotic surgeons, for the same reason, avoided the more complicated surgery. And this is an ongoing phenomenon. These are recent data from Australia, where you can see the total number of cystectomies are increasing, total number of ileum conduits is increasing, but orthotopic diversion remained the same. And if you look at how many men got an orthotopic diversion, it was 13.7%, and women fare even worse, with only 6% of women actually getting an orthotopic bladder substitution. And why is this? Well, the reasons against continent diversion in women that are discussed is the inferior oncological outcome, risk of urethral local recurrence, and inferior functional outcome. Now, if you go and look at the literature on survival after cystectomy in women, you will see that multi-center studies often have inferior results, whereas large single-center studies from high-reference centers show no difference. This is an old study from Mitra from USC, and they actually, in a propensity match score in over 400 women, found no difference in cancer-specific survival after cystectomy between men and women. And we did it recently in 200, so almost 300 women, also propensity match data from with 24 factors matched, and also found no difference in outcome in women. What we do know is they are diagnosed later, because the diagnosis is often missed and treated for recurrent urinary tract infection. So propensity match scores show that there's actually no difference after cystectomy. What's also being noted is that women probably respond better to neoadjuvant chemotherapy, and this equalizes the preoperative disparity in pathologic stage between males and females, and may have an impact in future on how we treat them in a neoadjuvant fashion. Urethral involvement. There's been a couple of studies looking at pathological data to see about urethral involvement. Here, Colaby and over 400 patients mapped where the urethral involvement was, and you can see that overall there were 7 to 13% had urethral involvement in the two studies, and this was only when there was a positive bladder neck. So you will only have urethral involvement if the bladder neck is positive. If bladder neck is negative, this is not a risk. When you look at the rate of recurrence, it's actually quite low. A recent multi-center study found a 2% recurrence rate, and solitary recurrence was only found in 0.6%. Risk factors, again, positive urethral margins, bladder neck involvement, and a trigonal tumor was actually not a risk factor for urethral recurrence. So that's not really an issue. Functional outcome. There is a lot of data on functional outcome in men, and you can see that daytime continence is around 87 to 100%, 100% probably not quite true. Nighttime continence is always a bit lower, 74 to 95%. And what also is an issue is intermittent continence diversion, intermittent catheterization, which was found in a low rate of patients, 1 to 20%. The 20% were from USC and Stein's pouches. Functional outcome in women is also quite good, a little bit lower, and the large disparity in results is due to the definition of incontinence, which is quite variable. Overall, daytimes 57 to 90%, the 57 were completely dry patients, nighttime 45 to 84%, so still quite good results. When you look at the need for intermittent catheterization, you can see that this is up to 61%. In Stenzel's study 11, in the rest of the cases, there is a high need for intermittent self-catheterization, which is one of the reasons people tend to avoid urinary diversion in women. Now in men, optimizing results, nerve sparing, was discussed already in the 1980s by Walsh and Donahue, who proposed this to improve erectile function. They also showed over time, in this multi-center study from Sweden, that nerve sparing also impacts continence rates. after prostatic surgery. In men, in our study, we were able to show that bilateral and unilateral nerve sparing are better than no nerve sparing. And what was surprising, these are patients that lived for more than 5 years, and you can see from 10 years to 20 years, actually the nerve sparing, the effect of nerve sparing becomes more apparent. So for some reason, as the people age, they actually profit more from the nerve sparing that was initially performed. Now in women, this was largely ignored. Nerve-sparing surgery was not really a topic, and this is neither gynecologists nor urologists, surprisingly. In this meta-analysis here, they found that urinary incontinence and frequency were less common after nerve-sparing radical surgery. And this sort of supports the fact that autonomic nerve sparing may be beneficial for urinary function in women. How do you do nerve sparing? The nerves that are important for nerve sparing, the bundles, they run along the lateral vaginal wall. So this means, as you can see in this surgical picture, you see the open vaginal lumen here, and then the clamp coming along the upper anterior wall of the vagina. That means at the 11 or 1 o'clock position. So you're sparing all the nerves that run along the lateral vaginal wall. We looked at our group of patients. You can see here daytime, nighttime continence, the overall results. We had a 64% continence rate, 36 incontinent. And if you look at bilateral and unilateral nerve sparing in the daytime continence, you can see that they do profit a lot compared to no nerve sparing at all. Nighttime continence was also affected, better results in nerve sparing, and you can actually differentiate bilateral versus unilateral versus no nerve sparing. So nerve sparing does seem to be beneficial in women as well. Now the next step would be reproductive organ involvement sparing. Also you spare the reproductive organs in women. And again, one shied away from this because of the anatomical closeness of the organs to the bladder. But when you look at it, your gynecological tract is only evolved in about 5 to 7.5% of patients with a urothelial cancer. And most of it is in the vagina, the uterus, and the cervix. The risk factors are a palpable mass, hydronephrosis, or positive lymph nodes. So there's not a lot of risk of your cancer being found in adjacent organs. If you look at here, functional outcome in reproductive organ sparing surgery in women. This is a very busy slide, so I summarize it here. Daytime continence rates 57 to 100%, compared to the 77 to 97% from a large study from Houtman, the ICUD EAU consultation. Nighttime continence 50 to 100% versus 66 to 86%, and intermittent self-catheterization 0 to 31% compared to 10 to 61%. There is a significant improvement in outcome with organ-sparing surgery. And sexual function, there's not a lot of data. There are indications that it is improved, but this is somewhat limited. We looked at our data, admittedly not really large numbers, and you can see that daytime continence rates with reproductive organ-sparing surgery are largely improved. These patients really profit from the organ-sparing surgery. When you compare this to the radical cystectomy group, you see a clear difference, and this was actually almost the same for nighttime continence rates. So day and nighttime continence rates in the reproductive organ-sparing group were almost the same. A recent pooled analysis and systematic review looking at traditional RC compared to organ-sparing RC and nerve-sparing. Daytime continence was quite good, between 75 and 79%. Not a lot of difference between the different types of surgery. Nighttime continence was impacted by nerve-sparing or organ-sparing surgery, and also the rate of intermittent self-catheterization came down in these patients from almost 30% to 16.8%. So there is a definite benefit. Now, how do you avoid voiding problems? Well, there's not a lot of data out there. Stencil always resected the proximal 0.5 to 1 centimeter of the urethra. We know that the continence part of the urethra is the mid-urethra, so resecting this part should not actually be a problem for continence rates. And we do once in a while see these hypertrophic proximal urethra shown in the picture, which causes problems with bladder emptying. Nerve sparing or organ sparing, as I showed, will improve your voiding problems. And then there's a lot of discussion about posterior displacement, and some people start to support the vaginal wall with the rotund ligaments or omentum behind the bladder to avoid kinking, and check or for correct for prolapse. There was a recent meta-analysis of how many patients after cystectomy actually need surgery for prolapse, and that was only 6%. So prolapse alone is not explaining this problem. And you sometimes wonder, as we say in German, what's the egg and what's the chicken? Probably these patients are straining a lot more to void, and this is causing the prolapse, and not the other way around, that the prolapse is causing problems to void. But that we don't know for sure. And the influence of simple or radical cystectomy on sexual function and pelvic organ prolapse. Here a scoping review of the literature in 2019, that's not that far back. And they say that despite the high risk for sexual dysfunction and or pelvic organ prolapse after cystectomy and diversion, a paucity of data and attention to these issues exists in women. And this is in stark contrast to the attention paid to male sexual function undergoing similar urologic procedures. Whereas considerations of surgical approach and technique on male outcomes is widespread, again, females' outcomes are lacking in comparison. There are some data, one here from a large series, female sexual dysfunction after cystectomy and diversion. The most common problems are loss of sexual desire and orgasm disorders, which are most frequently reported in 49 and 39%. Dyspareunia and vaginal lubrication are less common, but also 25 and 9.5% respectively. And the incidence of sexual dysfunction in nerve sparing went down to 10% compared to 59% with traditional cystectomy. So here again, there is a benefit from nerve-sparing surgery. What about health-related quality of life with a continent urinary diversion? Well, this recent study showed that RC patients reported favorable health-related quality of life recovery within 24 months, which is quite quick in most areas other than body image for ileal conduits and sexual function in both groups. Importantly, large measurable decreases in scores were not reported by 3 months after radical cystectomy. Body image, and this is me doing some photoshopping, which is not so great, but it is quite obvious that if you have this red thing sticking out and a bag over it, your body image is quite distorted. And this is an open surgery, but you can see the midline incision is almost invisible, and the patient's body image is normal. And this patient actually had a continent cutaneous diversion, but she was really happy with her body image. And the other thing with reproductive organ sparing surgery, women can actually get pregnant. And this was a young patient who came in and told me before surgery that she wanted to have another child. I said, well, we'll see what we can do. I can do organ sparing. Your tumor is on the bladder side wall, but please wait for at least 2 years after surgery to make sure we're kind of in a safe zone and your child will still have a mother. 9 months later, she came into clinics and said, I'm pregnant. I said, okay. Anyway, we also were always worried with the gynecologists about the need for cesarean sections in these patients, so we did a couple of MRIs. And as you can see here, your vascular pedicle always gets pushed to one side with the bladder. So going in for cesarean section is actually not a problem in these patients with continent diversions, be it a continent cutaneous or a neobladder. It's all moved to the side, and often they actually can give birth normally. So in summary, orthotopic bladder substitution in women does have good outcome. Patient selection, we did not say much about, but you need to have a competent urethra before surgery because it will definitely not be better afterwards. Nerve or organ sparing techniques will improve your outcome. And if you do a meticulous surgery with attention to details, you will get good results. So please do it. Thank you for your attention.